sharing interesting cases on the use of cardiac MRI in the setting of patients that are presenting with suspected acute coronary syndrome. So our first case presenter is Layla Gamash, and Layla's going to give us a very interesting case. Layla?
Thank you. Hi, my name is Layla. Thank you everybody for coming here. So I'll start with a case of 49-year-old gentleman, no really significant history, goes to gym, after a long time didn't exercise, so decided to get himself in shape, start exercising, feel chest pain, like pressure, radiation to the arm, 8 out of 10, feel lightheaded, nauseous with that, goes home, tells his wife, she drives him right back to ER. And then from his past risk factors for CAD, he's a smoker for 10 years, not heavy smoker, but still smoker, a couple drinks per week, and then his dad had an MI, but later in life. So EKG presentation, as we can see, there is ST elevations in anteroseptal, anterolateral leads with reciprocal changes in inferior leads. So with that, patient is taken to left heart catheterization, which shows, as you can see, RCA is pretty clean, left circumference is pretty clean, and there is ostial occlusion of LAD. Patient undergoes PCI to his LAD lesion, and this is post-intervention angiography result. As we can see, was able to restore the flow to LAD. Now, this is all again happening like the same day as patient presented, just a couple of hours. And then there is echo to see for the heart function. And as we can see, the function is down. We can see it's like not normal, like mid-30s. There is a wall motion abnormalities, apex and anterior anteroceptal wall is off, and even like infraceptal is slightly hyperkinetic. And there is a thickening in the apex. And with that, there was concern for presence of apical LV thrombus. So MRI was recommended to evaluate for the thrombus. So patient has MRI. This is the CNA images. Imagine like an echo. We just can look for the EF, for wall motion abnormalities, and they just put it the schematic. The different grading is just different degree of a hyperkinesis, the grading. And then as you can see, it's the same. It's an anteroceptal anterior wall is hyperkinetic with extending to the apical walls, and a little bit in lateral.
Quick question for you. What is that area bright around the myocardium? And go nice and slow. Tell us what it is.
It looks like pericardial effusion.
Okay. So
we can see small circumferential pericardial effusion. This information we knew from echo, we knew about the EF, we knew about wall motion abnormalities. Again, the question for us was LV thrombus. So I'm going to show one more actually, CNA images like long axis. Again, like for, all of us got used to seeing echo images, so some of this more familiar to us. And the same, we can see anteroceptal, anterior, apical wall motion abnormalities, and apex is indeed thickened. So, and again, next step is now to look for LV thrombus because that's what the MRI was requested for. And for that, we'll look for late gadolinium enhancements. And on the top is our CNA images, and on the bottom, corresponding late gadolinium enhancement images. That's where we'll look for the scar and for thrombus. And as you can see, so this is on the CNA, we see this is the walls that are abnormal, right? Like this is abnormal walls. This is an abnormal wall. So now when we look on LGE, we see that something is off, right? It's a dark, but it's not dark as normal myocardium. And it also has this rim of whiteness around it. So in MRI, we're able to say the scar and we're able to say the thrombus. So this is not typical scars that you guys used to see on MRI imaging that we usually show you. And even for us, when we get MRI, it's usually somebody, let's say, with a CAD, tree vessel disease, and we have MRIs like for viability, to see for reperfusion decide on reperfusion strategy. So usually the way how we see it is a little bit different, and I'll show you a different example.
So Leila, let me just make one kind of distinction here. We oftentimes use the term scar, but recognize scar is a chronic phenomenon, right? So scar is the healing process.
Correct.
That then becomes collagen scar. So maybe a better term to use for right now, because it is simply to say there's LGE or hyperenhancement. Now, what we know is that on delayed enhancement MRI, hyperenhancement can occur from chronic scar, but it can also occur from acute myocardial infarction as well, right?
Correct.
And so, again, just from a nomenclature standpoint, we don't want to use the term scar because we know this is acute setting here, this is likely acute infarct. So just either say LGE or just say myocardial damage.
So yes, so we see there is a myocardial damage in areas of hyperkinesis, right? So, but again, it's not something as we see typically. So as Dr. Shah said, as scar, because usually when we do MRI, this is something come to us down on the line, patient already had a damage, some time passed, and there is more chronic scar. So, and I'll just show you again, this is a short axis for the same, it's a different sequence, but it's a short axis to see again for LGE. And you see, it's this is the rest of myocardium, this area. Oh, I'm sorry. This area, but this is dark with a white rim around it. That's a hyperkinetic area. So we know, so there is abnormal hyperenhancement, there is a damage, right? So do we call it now, why it looks different from what we, you guys probably got seen when we show on the conferences, or even what we usually see a whole lot. I'm going to show different patient just to show what kind of, what we kind of got used to seeing more often. So this is somebody with a multivessel disease. As you can see, this is chronic. This is like the very thinning of around RCA and LAD area. Only thing really working in the circumflex. And with that, the scars we usually see, it's a or subendocardial scar or a transmural scar. But you can see that you see a little bit live myocardium dark, and then you see white or through or like in subendocardial region in relation to CAD. But the scar that we see, or even in here, you see, like it's a almost transmural scar with a normal myocardium. So the one that we see is a different. So, I'll try to play this and then. So as you can see, it's like the color is different. It's dark compared to regular myocardium, and then but it's in the area of hyperkinesis. So this is, again, it is damage as a result of an infarction and a reperfusion therapy, and it's called microvascular obstruction. So what is if we talk what is that, it's a complex process. It happens, it starts with damage to endothelium, to capillaries as a result of infarct, ischemia, and then so the endothelium already getting damaged, and then when reperfusion happens, so then there is a multiple things that happening. One is embolization of the plaque, then coming all the macrophages, neutrophils, then the endothelium get more damage. Now the fluid, extracellular fluid get increased. There is extracellular edema, compression on the vessels, and myocytes inflamed. So now you have, because of internal and external factors and inflammation and edema, there is a perfusion on capillary levels is compromised. So this, although we open the big corner is epicardial vessels, but on capillary level there is still obstruction, and this is what microvascular obstruction is. So
Leila, for 1 second, if you could go back to the dark blood LGE images for a second, just one thing, one more back, and one more to this particular patient.
So it just takes time. Okay.
Right.
You want this one or next?
You can go forward.
Fiddle?
Yeah, right there to the dark blood. Yeah. So when you see this, because I guess the big things that you need to be able to distinguish between is, could this actually be a thrombus that's layered on top of the myocardial wall, in which case, when you look at the cine images, you can't really appreciate what looks like a thrombus because it's a layered thrombus, right? And the key distinction between identifying microvascular obstruction versus a layered thrombus is really kind of two key things you look for, right? One is that microvascular obstruction has to be surrounded in 3D space by hyperenhancement, whereas a thrombus does not.
Correct.
Okay? So in this case, for example, you see the black area, right? But you see there's hyperenhancement all around in 3D space, the black area. The other thing, and you're probably going to show this to us later, is the other distinguishing feature is that if it's microvascular obstruction, the area of the black or the dark area progressively gets smaller over time, right? As contrast eventually makes its way in. Whereas if it's a thrombus, that doesn't occur. And so I presume you're going to show us later on, you have some
I do not have delayed images.
Some
to
delayed
show
images,
that.
because that's the key in making this distinction, is really to make sure that you go back at the end of your scan and redo. It doesn't have to be the whole, all the different slices, but at least one or two key slices so you can say, yes, do I see the area of the dark getting smaller and the area of the hyperenhancement getting bigger? That's what you're going to look for. So sorry, keep going.
Thank you, Dr. Shah, for comments. I do not have those delayed images to show, but it is the way how Dr. Shah said. So and I'll comment on that in that. So about microvascular obstruction, there is a way to judge about it. Like if you, after the reperfusion, if we had a slow reflow or no reflow, or if EKG was persistent elevation. So those are all signs that tell us, so although we open the vessel, so on microvascular level and capillary level, there is still obstruction, but MRI is a diagnostic modality for that because the way how we can see it. So it's very clearly seen. It is dynamic phenomenon. So this is a little bit different from what Dr. Shah said. Dr. Shah was saying even during the scan, initially we can see just perfusion on the edges and not getting into the core because of obstruction, but with time the core will get lightened up too. But what I say in here is this is a more as the time passes, because this edema will be essentially resolving and cooling down, so that scar that we see now will turn eventually to that classical scars that we can see, more dense, the connective tissue rich scar. And then timing-wise, I saw in the literature all the different times. It can persist up to 1 month to couple months. So sometimes when we have patients with ventricular ablation, so when we have repetition of them of the MRI in couple months for different reasons, we can see that scar is now a little bit dense, so maybe it's smaller a little bit, but because of edema cool down. And another thing is with MVO, because all the capillaries now dilated, damaged, so the erythrocyte can be spilling out. So that can be its essential prerequisite for developing intramyocardial hemorrhagic transformation. Not all MVOs lead to that, but it can lead to hemorrhagic transformation. And I want to show in our patient, and again, it's the same, it's going to be very dark looking, but one way to, and Dr. Shah, please add if you want to add, like if you think of something more. But like in this way, for example, there is a T2 star sequence that we do. We usually do it for patient with hemochromatosis. We'll look for iron deposits, and then with blood spilling into extracellular matrix, it start degrading. We get hemosiderin and all of these paramagnetic substances that we can apply the same sequence. And in this patient, if you recall, this area that was with MVO, and this was a normal area. And then when we do the sequence, we look for value, T2 star value, and anything under 10 is a severely abnormal for the heart. And as we can see in this abnormal areas, the numbers in 7, essentially around the 7. And the areas that does not have MVO, number is around 43, so it's normal. So this MVO does have a hemorrhagic transformation too. So with that, And one more thing, why we want to know if there is an MV or not, why to use these terminologies is important. It's been shown that if patient after STEMI have MVO, so usually associated with increased infarct size, adverse LV remodeling, so in diastolic volume and systolic volume, it doesn't remodel as good, so continue being bigger, EF continue being on lower side, and there is increased mortality and heart failure hospitalizations. So that's why, like labeling or seeing MV. Do we have to do MRI on every patient with STEMI? No, we don't have to. But like once we know, it's just good prognostication. That's all what I had.
All right, thank you very much, Leila.
Yeah.
Great presentation. Next, Alba Munoz is going to present another interesting case. Yours is on here, right?
It should be. Okay. Okay, so hi team. So today I'll be presenting the second case. So let's start with Mr. Jones. Mr. Jones is a 49-year-old male. He has a past medical history of cirrhosis secondary to NASH and hepatocellular carcinoma that developed into it, hypertension, hyperlipidemia, and diabetes. He also had a history of a left heart cath done 1 year before presentation that showed no significant coronary artery disease, non-obstructive. Mr. Jones, unfortunately, got into a motor vehicle accident, and he was transferred to a hospital where his course was very complicated by different complications, including splenic laceration that requires splenectomy. He had rib fractures with pneumothorax and other polytrauma. During that hospitalization, he also developed sepsis secondary to pneumonia and UTI. During the course of this admission, he developed some ST elevations on EKG and Q wave on the infralateral leads, but without any chest pain. He had rise and falls in troponins, and we can see here the trend that started at 500 and went up to 11,000 and then back down. So the rise and fall that we see with typical injuries in the heart. This is an EKG that was done before, the year before. So you can see that it's a normal sinus rhythm. There's no significant ST elevations, some D-wave inversions in lead 3, but nothing with acute ischemia or any damage. On the other hand, the EKG of that admission during that moment that they found the ST elevation, if you can see, it's a record from outside, so it's hard to kind of visualize, but I highlighted for you in the red box, and you can see how there is ST elevations in the infralateral leads. So at this point, the team was concerned, what is happening? Is this a CAD and type 1 MI? Is this a type 2 MI? Is this myocarditis given the high elevations of the troponin? And the team decided to, first of all, rule out the most important one, the obstructive CAD. So the patient went for a left heart cath. In the left heart cath, and I'm going to show you the pictures, they basically didn't see any significant obstruction. So there was some CAD, but nothing to justify the elevation of the troponins or the ST changes in the EKG. So now the question remains, what's going on? So because of that, the team decided to go on and do a cardiac MRI, and that's where we come into place. And
I just want to make one comment,
Okay.
which is I like the way that they're managing this patient. One of the things I oftentimes will sometimes see is people say, let me skip the cath and go straight to the imaging. But remember, the diagnosis of the secondary phenomenon is after you've excluded obstructive coronary disease.
Exactly.
So absolutely you need to do a coronary angiography first before you then go looking at the myocardium itself.
Exactly.
So keep going.
Yes, so we rule out the coronary disease, and then we go on for the MRI. So for the MRI, as you can see, these are the cine images. As Leila mentioned, here we can see function, we can see structure. And if you see by the arrows, the wall motion in the base and the mid of the ventricle is normal, but as you get closer to the apical segments, the infralateral wall seems to be akinetic, and you can tell. Now we move to the inversion recovery sequences, where we can see if there's any scar or any LGE. And as you can see, I laid for you the long axis view. So this is the area where we saw the wall motion abnormality in the short axis, so the inferolateral wall in the apical segments. And as you can see, that correlates to the area where we have subendocardial scar. Usually this pattern of scar is due to an obstruction or a coronary origin. As you can see, the rest of the segments that have normal motion also have no scar. So this is the inversion recovery, but this is a single shot view, so we can see just the video of the play of the short axis. So you can see slowly how, as we go into the apex, we start seeing the scar, and it's also endocardial and transmural, covering most of the muscle thickness. So now you go back and you say, maybe I missed something in the calf. Maybe there was a lesion that I didn't see that can justify this finding.
So, and maybe what we could do here is that, at a point like in time like this, what you're looking for on the MRI is not just the fact that, do I see hyperenhancement or area of LGE, but it's what is the location and the pattern, right?
Exactly.
Now, because it could be multiple patchy foci that make you think of something else. In this case, you're seeing a pattern that looks almost transmural. It looks like very much like this could be in a coronary artery distribution, right?
Exactly.
So after the MRI, your working diagnosis is this person, that enzyme bump that you had is due to myocardial injury that's from a coronary etiology.
Exactly.
Now, coronary etiology, though, is broad-based. It could be obstructive coronary disease. It could be in situ thrombus that's formed, a 10% lesion that the plaque ruptured, they developed a occlusion, the vessel could have recanalized itself. It could be an embolism, right, that also then leads to a coronary pattern of myocardial injury or damage. So you've got a variety of different things, but I think the first step is to say, what is the pattern of the hyperenhancement you see to tell you, is this pointing towards a non-ischemic or an ischemic coronary etiology, right?
Exactly.
And then absolutely what you're going back and looking at the cath again to say, okay, is there a flush occlusion that maybe I didn't appreciate? Is there some haziness? Could there be a dissection that you may not have appreciated on the initial glance? Okay,
Exactly.
so keep going.
Yeah, so as we said, as we saw before, based on the pattern of the scar on the MRI, we're leaning towards maybe there's something epicardial going on. So before we go ahead and rule out other causes, let's just make sure that we didn't miss it on the first calf. So here I just put together for you to see the images from the calf that was done a year before and the images of the calf done at the moment. I just put the images of the RCA and the circ because that's the territory that was affected on the MRI for you to see. So if you see here, that was 1 year before, and it looks pretty clean. There's no significant lesion that can justify this. And as you can see, at least approximately on the circ. And then as you go here, that's before. I'll freeze it, and I'll play the one here. Nothing. Nothing. And then we go back and we see now the RCA. Looks clean. And no significant disease. So with this, and no other findings, so we go for diagnosis of MINOCA. So MINOCA, as you know, is a broad spectrum. We are not pointing out what's the etiology, we're just pointing out the condition. So the diagnostic criteria for MINOCA would be that you have evidence of myocardial infarction. And for that, we go back to the fourth definition of MI. And that should be patients that have elevation in the troponin that is more than 99th percentile. You have the rise and fall. And then you have one of the following, either symptoms of MI, new EKG changes, ischemic, the development of pathological Q waves, or you have imaging with evidence of myocardial necrosis or damage. And that's what we have on this case. We have the rise and fall, we have the EKG changes, and then we have the MRI showing the MI and the damage. Then you follow and you say, okay, I have no obstructive coronary lesions, and that is defined as less than 50% stenosis. And then you have to rule out any other causes that can be explaining the rise and fall of troponin in this case. And these are things like sepsis, like PE, like myocarditis. And that's what we did with the MRI on this case. So this is the kind of algorithm that is proposed to work on the diagnosis of MINOCA. So as we see here, the first thing would be to have the concern for injury to the muscle. Then you rule out any significant CAD, and then you consider other diagnoses, sepsis, PE, myocarditis. And then you want to make sure that you really didn't miss any significant lesion on the calf, and that's what we did. And then you look for any other reasons to explain this. SCAD, Takotsubo, myocarditis. And this is where MRI plays a very important role, because MRI is able to tell you if there is any myocardial necrosis or damage, and what is the most likely etiology for it. Is it CAD? Is it any cardiomyopathy? Is it Takotsubo? That is not considered MINOCA because it has another different pathophysiology, or is there any other cardiomyopathy? So once you have that, then you have a different list of causes that can cause MINOCA. And that includes plaque rupture. And all of this, just remember that you can have this, but the key is that whenever you do the angiogram, you have no significant lesion, okay? So there could be that an embolus came and dissolved, and by the moment you saw the images, there was no obstruction. It could be vasospasm. It could be coronary microvascular dysfunction. It could be SCAD. So it's very important in these cases to also have OCT or intravascular imaging that can really tell for any other of these causes. So these guidelines say that basically CMR is recommended as a key investigation in MINOCA. And the reason being is that it can exclude symptoms like, or syndromes like myocarditis, Takotsubo, cardiomyopathy, but most importantly, it can determine the presence of an MI. And the management of MINOCA would be in 4 different steps just to cover any emergency, so supportive care, work up the most likely etiology for this, and treat on the basis of the presence of MI, and then finding the causes so you can treat the specific cause. And why is this important? Well, MINOCA in most studies have shown to have a better prognosis than a CAD MI, but not in all studies. And there's a substantial risk for recurrence of events in the general, when you compare these patients with MINOCA compared to people without any cardiovascular disease. And it has been shown that the presence of ST elevation, like in our patients, heart failure or shock, has a strong predictor with in-hospital death. And Mr. Jones, he was treated for the MI, so he had DAP with Plavix and aspirin. He was already on Topro for other diagnosis and on ARP. So he continues to do well and without any recurrent event.
All right, thank you very much. Great case. And then next, Anish Dor will be presenting, I think, 1 or 2 cases, right? 3 cases, if we have time.
As we have time. Okay, good afternoon, everyone. So my cases are actually going to be a lot of show and tell, so not a lot of teaching. You guys will participate as much, and we'll try to keep them fun. So let's start off. So 37-year-old female. She has a past medical history of trigeminal neuralgia, and she directly comes from the ER. She directly comes to the ER from a neurologist's office, where someone was doing a nerve block, And she's had multiple of these nerve blocks in the past, but this time she had a syncopal event, her blood pressure was really low, and it responded to fluids. The initial workup, because she's come to AER, she got a high sensitivity troponin, and that was 516, so our normal range is 19, so this was elevated. NT-proBNP was not that bad. And that was her EKG, and that's the troponin trend as she comes in. So on the EKG, almost, I would say, non-specific. And on the troponin trend, there is definitely a rise, and it is falling down. We just don't know what it was prior to presentation. So, and then this is the echocardiogram done as soon as she was admitted. That's a parasternal long axis view, a 4-chamber view, a 2-chamber view, and then a subcostal view. So this time, is anyone there? I guess I'll just go through it quickly, but mainly what you can see is that it doesn't look normal. A 37-year-old heart should not look like that. It looks like the middle of the ventricle isn't contracting really well, but the apex otherwise is doing decently, at least on these views. You can see pretty well actually in the subcostal view, where the apex seems to be working well, but the mid-ventricle isn't working that well. And
Now,
so,
Anish, I guess one question that would come up, how confident are you about the apex here, or could you just be foreshortening the apex?
yes, so you could easily be foreshortening the apex. So again, echo being more dependent on the technician and not a traditional cross-sectional imaging, you can miss that. In this situation, you can see the apex well, and if you really want to try and get a better image, you could probably do ultrasound enhancing agents in this situation. But yeah, if I was the echo reader of the day, I would be confident saying that, okay, something is wrong with the mid-ventricle and not so much with the apex. So I think, like, just to open up to the general fellows over here, right now you're thinking about a 37-year-old female with a clear event, something has happened, and now she has this pattern on her echocardiography with the troponins that you did see when the patient came in. What would you suspect? Just straightforward, don't think too much. And again, yeah, maybe 30 years ago when it was not a very well-recognized disease pattern, people were more worried about it, but now over the last maybe 10, 20 years, we have increasingly realized stress-induced cardiomyopathy, and it's way more common than we think. And so one thing that we have to do, even in stress-induced cardiomyopathy, is to make sure that the coronary anatomy is well delineated. So that was done in this patient. And in this case, you can actually see that the patient actually has a type 2 LAD, where she has a very large diagonal branch, and the true LAD actually goes through the septum. It's hard to notice, but there is bridging off that mid-LAD segment. You can see it better over here in an RAO cranial view. And then the RCA was completely clean. So at this point, I think we were more confident that this is a case of stress-induced cardiomyopathy. The reason why we ended up going for the MRI in this case was just to mainly look for any occult myocarditis, and she was about to be discharged to see if there is any recovery of function. And so we ended up getting the MRI, which is a very pretty echo. Here you will not miss out on the apex because we are reformatting the images cross-sectionally. So this is a balanced SSFP or SSFP image of the 4-chamber, and the image at the bottom is a inversion recovery LGE. So what you can see is that again, the mid-ventricle is not contracting as well, but the apex is, very similar to the echocardiogram, and there is no scar in the 4-chamber. Similarly, a 2-chamber, which is seen even better, where the apex is slightly hypercontractile, whereas the mid is not that well. And then in terms of the LGE, again, we're not seeing any much scar or any scar. And this is the 3-chamber. So that's kind of what wrapped up this case. Was we actually did get the patient's post-echocardiogram a month later. So these are the different types of, again, Takotsubo variants that we have seen. In our case, it was the mid-ventricular variant. And then a month later, the patient gets an echocardiogram. This is probably the best evidence that this was all stress-induced, is when your ejection fraction has now come back to normal, or your contractility is back to what its baseline is. But yeah, that's the first
So,
case.
Anish, let me ask you one question. You showed us that there was a modest elevation in cardiac enzymes, right? What was about 500 or so,
Yes.
and your upper limit of normal is 20. Okay. But how come you don't see any LGE?
So in this situation, so there is, I would say, in terms of troponin release or myocardial injury, it does occur, but the level of myocardial injury may not be at the same resolution of what imaging we get. So there could be some scar which we're not seeing, because the resolution of our imaging right now is about 1.8 by 1.8 millimeters, which is really good, but it's not at the level of a myocyte. So that could be one explanation why you have a very mild release, but it's not causing lasting damage.
Yeah. And I think the other thing is that in this, it's over a broad region of myocardium where the damage is occurring, right? So it's kind of a few cells are getting knocked off across a wide variety of myocardium, versus that same amount of myocardial injury that gives you a troponin peak of 500, it was all in one focal area.
Yes.
Right, you'd have a significant amount of myocardial damage, and you'd see hyperenhancement in that area. So here, I think it has to do with the fact that the myocardial injury that's occurring is occurring over a broad area of myocardium.
Yes, oh, thank you so much. And so that wraps up the first case. I think, do we really need the MRI here? I think in retrospect, if in a different center, if you don't have MRI available, echocardiogram actually was enough for a case like this, which takes me to the next case where MRI really does help a little bit. So 46-year-old female, this is a little bit more complicated history. She has a history of known vasospastic angina, and she presented in the middle of the night with monomorphic VT. So she's been diagnosed with vasospastic angina about 2 years ago, and she's had recurrent crushing chest pain with the STEMI on the EKG. She's had a left heart cath before with non-obstructive CAD. The first time she was diagnosed, she stopped smoking, and that helped abate her symptoms for about a year. She then actually underwent a stellate ganglion blockade for her vasospastic angina, but then 1 or 2 months after that, she actually comes in now with a anterolateral STEMI and a left heart cath, which we'll show with 20% ostial RCA, and which worsened to about 60 to 70% with hyperventilation. So that's the EKG, and this one, light as day, you are seeing ST elevations in the lateral leads, and there are reciprocal changes. And there's actually also in V2, so in the septal leads as well. And this was the VT which was actually seen in the hospital on the hospital telemetry. It was 3 minutes is what they clocked it at. And so this was her cath. So this is an areocaudal view with the LAD coming across the screen and your circumflex going down. Overall looks non-obstructive, and that's the RCA, where there is some dye hang-up, but I don't really see a lot of stenosis. They did mention that when the patient hyperventilated, that stenosis went to 60 to 70%. But I think, and that's the areocranial view. And that's finally the elaeocranial view. And so now I think I'm going to jump to the CMR of this patient. So the reason why they ended up getting a CMR in this case was that patient was having VT, and they kind of wanted to see what was going on from a scar standpoint as to is there something that they can intervene upon. And so to start off with the SSFP or your images, this is basically her function. So her overall LV function, as you guys can see, is actually pretty well preserved. One thing I do want to point out is the SSFP image is a T2 over T1 image. What I mean by that, and these are a little bit more from this general cardiology fellow standpoint, but a simple way to think about it is that T2 at least is something where you see if there are more protons, you will get a higher signal, to think about it simply that way. So what I'm trying to get at here is that this area is brighter which means that it likely, in this particular sequence, there's a higher T2 signal, which could translate down to more protons, which could mean more water content in that septum, which finally translates to edema. So it's very important to see that that's the way that we go about it. It isn't just directly saying that there is more edema, there's a pattern or a method to our madness. So that you can see clearly just off the bat. Then when you go actually to the late gadolinium enhancement images, you can clearly see in that LAD territory, there's a large area of scar. And the white over here is areas which have very high or a short T1 time, which means it's hyperintense, and that's how we identify scar. Now compared to the...
Anish, let me just again, would you say there's scar there, or...
I should say late
semantics.
Yes,
right.
late gadolinium.
There's late gadolinium, because again, this could be acute injury, or it could be chronic scar, so don't use the term scar, because in this case, I think from the clinical presentation you're telling me, from the fact that you're seeing alteration in the T2 signal on your cine, suggesting that there's increased water content and edema, you're going to tell me in the end that this is an acute,
Yes.
right?
Yes.
So don't use the term scar.
Yes, that is true. So there is late gadolinium enhancement. But if you notice, compared to Layla's case from the start, where it was a thick myocardial segment and there was late gadolinium enhancement, there is no black pattern here. So compared to MVO, where it is hard for gadolinium to reach the particular part of the myocardium, here actually, because we've known the cath, it's going in pretty easily. That means that the entire myocardium is picking up gadolinium. Now, if you wait longer in an MVO case, you will see the same, but this was just for us at the timing that we saw. So that's, and this again, we're just demonstrating better in dark blood LG images. It starts at the subendocardium and goes all the way to almost the epicardium. So it's a large area of late gadolinium enhancement. The other thing that I wanted to point out is actually what we do is the T2 sequence, which is done pre-contrast. Trying to see where the map is. But if you can notice that this is the T2. It's not. No. Yeah. So in the T2 signal, the T2 image over here, this is a scale of what the different level or the different T2 values are. And as you get closer to the white, you have a higher T2 value. As you get closer to the black, you have a lower T2 value. Very importantly, this is done pre-contrast. So this area having a higher signal is likely from higher T2 value. Again, what we could see on the SSFP image is just more clearly seen here. It's less likely to be blood pool because of the fact that it's so far in from the subendocardium. So putting all of this together, it comes out to be, we would classify this as a case of acute injury with late gadolinium enhancement and acute inflammation, at least on the basis of this CMR. And so using these, basically this information, the decision was taken for the patient to not only have an implantable cardioverter defibrillator, but also to actually undergo bilateral sympathectomy to try and reduce the burden of the catecholamine surge and reduce not only the vasospastic angina, but also to try and reduce the VT episodes. I think they kind of did a kitchen sink approach because they wanted to make, this patient is young and she's having a lot of symptoms. And actually at 1 year follow-up, she did not have any more symptoms. And on her constant ICD checks, she does not have any more VT episodes. She actually underwent a post scan as well, where now you guys can actually see how a device scan and a non-device scan, how different they are. So you can see it's still pretty good in terms of when we scan patients who have devices, we do still get good endocardial border definition in most cases. The scar definition is altered because of the artifact from the device, but you can still see that same area of scar is still, not scar, I should say, late gadolinium enhancement is still persistent. But overall, so far, the patient has a good outcome. Now she's I think, a year and a half out from that original bilateral sympathectomy. Yeah. And so that was case number 2. And the last one for the day, oh, where is my, here. So this one was the most interesting, and I've kind of kept it short because it's a very long case, but I wanted to keep it short. It's a 60-year-old male with a history of antiphospholipid syndrome, heparin-induced thrombocytopenia, CKD, Addison's disease, who actually had prostate cancer and came for a radical prostatectomy with pelvic lymph node dissection. So it was a pretty big surgery. Post-operatively, the patient goes into cardiogenic shock, and that's evidenced by low cardiac output, a hypotension, and he has a STEMI on EKG. Now, the patient at baseline had low voltages, but even in a low voltage EKG here, you can clearly see that there are minor ST elevations in 2 and AVF for sure. 3 is kind of hard to see. But this, coupled with the fact that the patient's high sensitivity troponin started off at 3775, so this is after the cardiogenic shock, and it just skyrocketed in the next 36 hours to about 10,000. So he initially gets an echocardiogram, which has a normal LV function and no wall motion abnormality. He isn't really complaining of chest pain, and with everything that's going on, he's also thrombocytopenic, and his creatinine is rising at 1.9. He also has shock liver with an AST of 1500 and ALT of 4000, which are normal when he came in. So seeing all of this, the interventional team, even though it was a STEMI, was called, and they did evaluate the patient, and they avoided the cath initially, primarily because of the shock liver and coagulopathy, with the rationale being that right now they would not be able to do any sort of intervention, given that the patient would have to be on dual antiplatelet afterwards. And with the entire picture not looking like a clear, like ischemic ACS, they were thinking more like, okay, let's try and see if this could be something else and not that. But yeah, go on.
Why is this cardiogenic shock at normal echo?
So that was actually, the reason was the right heart cath. So initially when they had done the central line and done an SVO2, cardiac output was low on that. So that's kind of how they presented it. And then the patient initially was on like levofed as well as dobutamine. So probably the echo could have also been on pressors. So that's one thing, at least from my quick review of that. So then the patient eventually gets a CMR when they're stable. So this was day 3. That's why we have so many troponins. And I'll quickly jump to that. So So in this case, just for the fellows to see, when patients really can't hold their breath, your image quality does suffer, but now we have tips and tricks to try and salvage these studies, and we call this real-time imaging. So we are still doing gating, I mean, to a certain extent, but you can see when you compared these images to that first patient that I showed you, you do have one caveat to these patients where you can't really get great images. But so you can see, okay, to start off with this case, so in this case, the ejection fraction does appear to be reduced. I would say, I think we've eventually calculated out to be anywhere between 35 to 40%, so it's moderately depressed. But there is no regionality to the wall motion. It looks very global, and that's me going through now the 4-chamber view, the 2-chamber view, and then the 3-chamber view as well. But with all of this, even with the real time, we actually have very good late gadolinium enhancement sequences. So in this situation now, just to turn your attention to this late gadolinium enhancement, so it is actually a ring-like late gadolinium enhancement throughout the myocardium. It's sparing the endocardium, and it probably is involving the subepicardium. So this is what we would call a classic subepicardial LGE pattern, and more like a ring-like enhancement of the LV. And that was, for me as a fellow, I was banking on this being ischemic, but when I actually saw these images, I was like, okay, I need to learn a lot. So this is a very interesting case for me personally. But yeah, so this is something we would typically see in a myocarditis kind of a picture because it is diffuse. It's not necessarily patchy because this is an extensive amount of late gadolinium enhancement that we're seeing. And then that can be well demonstrated also on our dark blood or fiddle sequences for LGE. So this patient then eventually did end up getting a biopsy which had lymphocytic infiltration of the myocardium and did get a cath. The cath was clean, so it's not like we skipped out on the cath, but it was just delayed because as I said, they wanted to try and see what was going on before. But that is the areocranial view with the LAD looking pretty clean. And elaeochordal view with circumflex not looking too bad. And RCA was also completely fine. So yeah, so this was a case where, I mean, honestly, clinically speaking, I would have probably taken to cath right away, but because of the other clinical scenario going on, the deference of the cath was not unreasonable. The MRI did help with the diagnosis because after this, the patient was started on steroids and was treated for myocarditis and had a very good outcome. Eventually was discharged on, I think, day 30 and then followed up pretty well. But yeah, any questions, comments on a case like this? You can go back to the MRI images. Yeah, I think that's about it. That's all I have for you guys.
All right. Well, first off, I want to thank all the fellows. These are outstanding cases. And again, I think that if I were to kind of wrap it up, I think where the strengths of MRI in these types of presentations is, there's an enzyme bump. So there's myocardial injury that's occurred, but the question is where and what's the pattern that gives you a clue as to what it is. So it's not just simply identifying that there's myocardial injury, but it's actually the pattern of it, which is different between ischemic heart disease versus a variety of non-ischemic conditions like you're showing us here. And that's where I think the MRI can be very useful. But I think always also recognize all of these are diagnoses of exclusion after you've excluded obstructive coronary disease. And the reason for that is because if the person has a high-grade coronary lesion or coronary obstruction, every minute that goes by, there's further myocardial myocyte injury that's occurring. And so you need to do the cath right away to identify something that's actionable before you go and try to identify these other things. So I think that's all, for the general fellows, very important, cath first in these types of cases. All right, thank you very much. Great presentations, everyone.